What I'd kind of like to do as a starting point for this evening is just give an overview of PBCers Organization. PBCers is here as not just a support group. We spend a lot of our energies as an advocacy group in the patient community, and we work hard to provide education and resources. As I've mentioned to a couple of you that I've met in the last few days now, this is a journey, and we're all on a journey of PBC, but no two journeys are exactly the same. Whatever stage you are, whatever other issues you may have in your health situation, all of those are different for every single one of us. There's commonality, certainly, but I'm finding as I delve more and more into this disease, there's more that's different than the same sometimes. So I just want that to kind of percolate in your mind as we're going to go through some of these slides and not all of them. This is a slide presentation that we put together for the liver meeting, which is hosted by AASLD, and we were in Washington, D.C. last October with this particular material. And part of the goal of that was to educate the doctors about the patient experience. They understand the disease. Don't ever doubt that. They know more than you want to know they know. But they don't live with it. We live and breathe this disease every day. So there's another perspective to that. And one of those perspectives is being a collaborative member of your care. So that's my first point that I want to bring up. So as we kind of flip through some of these slides, we're going to go through most of them fairly quickly. We were primary biliary cirrhosis, and as Dr. Gish mentioned, there was a collaborative effort to change the name from primary biliary cirrhosis to primary biliary cholangitis. Anybody here know why?
Well, because most patients no longer progress to cirrhosis because of the medicines.
Right, they're diagnosed earlier, and cirrhosis may never be in their journey, right? But the connotation of the word cirrhosis can be very devastating. People have lost jobs, they've been unable to procure insurance, health insurance, life insurance. There are some real ramifications. There's also some prejudice against the word cirrhosis because it's unfortunately viewed as a lifestyle issue. Most people think cirrhosis and alcohol. We know better. That's not true. But with our name saying cirrhosis, I've personally had a very senior nurse walk in my emergency room as I was having a very critical medical issue unrelated and say, why are we wasting resources? She has cirrhosis. That is why I do what I do. All right, so now we're primary biliary cholangitis. So what is it? It's an autoimmune liver disease. It's also an attack of your immune system on your small bile ducts. We have a couple pictures coming up that get into the whole liver and the tree, the gallbladder, and how it all works. So we'll briefly go through those because I'm not going to educate you about this disease that way. But you can see the liver and how it functions, the biliary tree, the green with your gallbladder, right? And now we're going to dig in a little deeper. That green, those bile ducts, these. This is what gets affected. In a healthy liver, it looks like that. But with PBC, that starts happening. And as it starts happening, these start getting more prevalent in your bile ducts. And eventually, it just ends up destroying them, slowly but surely. Okay? Who's at risk? 9 to 1, women. 10.
It's gone up.
It's gone up. Most common autoimmune diseases. We also know that autoimmune disease tends to not just be one. So it's not uncommon for us to have more than one. It's considered a rare disease, but that's what it does. Because it is rare. And how many people know somebody else with PBC? Does it leave you feeling afraid of your future and what it means? How to deal with it? Powerless? That's a mistake. We can fix that. That's why we're here. We're not powerless. That's why we're here. That's exactly why we're here. Okay? Yeah, as you can see, we've got a depiction of all kinds of people because everybody can get PBC. This isn't a genetic, it's not a socioeconomic, it's not a lifestyle, it's an autoimmune disease. So we're here. What do? We're here so no one feels alone. So no one feels afraid. Can't change the fact that we have PBC. There's no cure, but you're not alone. We're here for education. There's a brochure over here on the counter. If you'd like, help yourself. A lot of this information is in that brochure as reference. Okay? Symptoms? Some people here have no symptoms yet. Some of them have one or the other. Some of us lucky ones have both. Might have others, especially as it progresses. Other autoimmune diseases. Does anybody here have other autoimmune issues? Not uncommon at all. Raynaud's, hypothyroidism, or Hashimoto's, Sjogren's, scleroderma, arthritis, celiac sprue. Those are all autoimmune diseases that are not uncommon in PBC patients. How is PBC diagnosed? Okay, 2 out of 3 features to get a diagnosis. Elevated alkaline phosphatase. If you don't know what your alkaline phosphatase is in your lab works, find out. You should know. It's really important that you educate yourself. We'll talk a bit about why. A positive antimitochondrial antibody test, and if necessary, a compatible liver biopsy. We don't do liver biopsies very often anymore because the first 2 now are considered diagnostic, provided that that elevated alkaline phosphatase has been over a period of time. Not if it's up one time and 6 months later it's back down. It has to be elevated for a period of time. Your experts over here will go into that in more detail. So how do we treat it? Everybody here on ursodiol? Yes? No? You're not on ursodiol? They took you off. Are you not tolerant of it? No. Okay. All right. So ursodiol is still the most common treatment. There's also a newer drug that's been approved in the last 15 months or thereabouts, coming on 2 years, obeticholic acid. And so most people respond to ursodiol, or UDCA. That leaves 40 that don't, right? 20% respond to both drugs. Now we're down to 20%. Now what? So you can use one or the other individually as it's appropriate. There's some criteria that has to be met. And 20% respond suboptimally. What does that mean? It means it doesn't get your liver panel back down where we all want it to be, right? Close enough to normal. There's some ramifications if it doesn't happen. So then what? The good news is there's still new trials and some new drug therapies that are in current clinical trials that are showing some real promise for us. Okay? So right now, those are our treatment options, and this third line here is what's coming. But we do know if you don't treat it, what's going to happen. Follows a course. It starts with a very silent disease that you're not even going to be aware you have anything. If you're asymptomatic like you are, how do you find out you have it? It could just be a fluke of a blood test, right? as we move along, symptoms can bring you to a doctor. That's how most of us get diagnosed, because we are symptomatic. We have itch, or we have fatigue, right? As the cholestasis, the liver bile ducts get destroyed, you start advancing into some real problems with the liver, and there are some complications of that, all right? And lastly, unfortunately, still, the only final treatment, if you will, is a transplant for those that require that. That's how we are today, okay? So, snapshot view of how the disease progresses, but we're here for support. Because we're all on this journey. Wherever we are on that scale, we're here for this. And our community, that's why I'm here. Because I live up in Northern California, up in wine country. But there's been a request from you folks to do something here. So we want to respond to that and be responsive to that for the long term. We're here to help you connect with one another, to connect with resources that we can provide, information. Knowledge is power, absolutely. Physicians, fellow PBCers. We raise money for research. We have a fundraising arm that all we do is raise money for research. All the donations that we get go to research. Because we want to find out what causes this. We want to know better how to treat it, meet the unmet needs, because there still are unmet needs. There are people that can't take ursodiol. So what do? Can they take the other drug that's approved? Maybe, maybe not. Then what? So there's still stuff to be done. And lastly, a cure. Wouldn't that be nice? My daughter has AMA positive antibodies. She's scared to death she's going to get this disease. But just because she has that doesn't mean she's going to actually develop PBC. So we want to be there for everyone. We're on a mission to support you. That's why we're here. That's why I'm here. That applies to your family members and your friends. And I really applaud you for coming, because that's a true friend. Somebody who's there thick and thin.
You don't know my show.
We raise funds for research and eventually a cure. And that's why we're here, to connect you to all of that. So PBCers has a mission to offer support, education, and resources. We fund research. There's a couple things that we really want to focus on. And some of those are, as I mentioned earlier, collaborating with your medical team. Collaborating means tell them everything. Even if you don't think it's part of PBC, tell them. Because what you don't know can hurt you. But if they know, then they can put pieces to the puzzle together. And that's what we're talking about here, being educated. The other thing is follow your doctor's advice and the treatment plan. Don't go rogue. Don't go putting things in your body that you don't know what they are. Talk to your doctor. They're the experts, and they know your disease state and anything else that's going on. So many patients have other medical conditions, and you don't realize somebody says, oh, well, if you just take this, it's natural. It'll help you. Yeah, okay. That may be good for them, but you better talk to your doctor before you do anything. Supplements, herbals, homeopathic remedies, liver cleanses, all of those things have consequences. I'm not saying they're all bad, but supplements are not regulated like medication is. And you don't know what's going in and what it may do, you better find out first. There are people that are having really bad reactions to certain very healthy things, like green tea extract. So we're here to educate about that. Okay. Also here to help you educate your family members, your colleagues, your friends, your church group. Your ancillary support system is part of that education process. There are some PBCers that don't believe in sharing their disease information. They don't want to worry people. They don't want to make it seem like, oh, poor me. People see things that you don't see. They may recognize something you don't. And that could be a huge tool for you. It's also support. These people care about you. They're in your lives. Don't shut them out. Okay? So education means empowerment. It gives you control over your disease, and working with your doctor, that's an awesome team. That's how you're going to succeed at making this a part of your life, not your life. Okay? And another piece of information, things I've learned in this journey, and some of you have experienced the same thing. Don't mistake friendly advice for medical advice. Talk to your doctor. I am no doctor. I know more about PBC than I'd ever want to, but I'm no doctor. My doctor signs off on everything. Every medication, every change in my diet that is even remotely affecting my liver. Everything. Anything that goes in my body, he knows about. Okay? That's how I stay connected with my health team. That's how I learn about my disease and share that with people that have this disease, and how we work together to empower you. So along that line, we have a website that we just launched yesterday, our 2.0. And our website's been pretty much the same since 1994. This year we went through a major revamp. So I encourage you all to go there and explore. Learn about the disease, learn about the support, learn about local people that have the same disease as you that you can talk to. You may choose not to all get together. You may choose to do that one-on-one. There are so many people I talk to all over this country that have PBC, especially people that are newly diagnosed. Those are the ones we really can support because you know what it was like. You've been through that journey of sharing that whole fright and discomfort and not understanding anything. These are places that you can go to learn, okay? Don't speculate, don't wonder, educate yourself. Get the facts. If you don't know, get the facts. They're out there. Beware, don't go to Dr. Google, okay? I can't stress that enough. Not even all the sites that have PBC information are current. There are plenty of them out there that still say the name's primary biliary cirrhosis. Okay? Don't go to Dr. Google. That's not your source. Go to reputable sources. And if you don't know who those are, go to this source and we'll tell you. They're all listed there. We're very transparent that way. And a lot of these wonderful doctors will sit and answer our questions, and we put those answers up on our website because we all have questions. Okay? Be engaged, not consumed. It's so easy to let PBC take over your life, but it's not your life. It's a disease you have, and your life goes on. Especially when you're newly diagnosed or when you find out something's changed. Those two tipping points can make a big difference. Positive attitude is huge. Okay? So we're the largest support group in the U.S. for PBC. There are other support groups around the country that are smaller, and there are others around the world. There's one in Canada, there's one in the UK, there's one in Australia, New Zealand, and China. So we're building that network. We talk to everybody. We are all inclusive that way. We also collaborate with other groups, like the American Liver Foundation. We collaborate with the National Organization of Rare Diseases, or NORD, ARDA, which is autoimmune diseases. Lots of organizations that way. A couple of real quick things that I want to touch on. In your packet here, you have a document that is a collaborative document. It's called a white paper about patient-centric care for PBC. This is something that several of these organizations that I just mentioned, the ones in Canada, the ones in the UK, us, American Liver Foundation, with the help of our friends at Intercept, helped us write this as a way to communicate to people in the medical field as well as patients about why considering the patient's perspective is so important in this journey. Why we encourage you to talk with your doctor. Don't let them talk to you, talk with them. It's a big difference, okay? There's also, and it's available on our website at PBCers.org. It's also available on the American Liver Foundation, liverfoundation.org. This is a PBC Patient Bill of Rights. Again, it was a collaborative effort of the groups. We came up with some real touch points about what's important from a patient's perspective, and things like getting the best care and treatment, getting to know your alkaline phosphatase levels. And you should know what your blood tests look like and track them over time. Don't rely on the lab to do that for you. It's too important. Understand how your treatment's supposed to work, and work with your doctor towards a goal. This isn't a race that you're gonna win, because there's no cure. Your win is gonna be keeping your PBC from progressing as slowly as you can. And many of you do. 10, 20, 30 years and people don't progress. That's the goal for now, okay? So that's available to you as well, and this information. If there's any questions, I'm happy to answer them either now or later. And if you would like to help yourself to the materials that are here on the table, one thing I would encourage you, if you're comfortable with it, get yourself one of these. It's a PBCers pen. It says, hey, I got PBC and I'm okay with that. And I'll share that because I'm not the only one who does. Thanks for coming. And again, if I can answer questions, I'm happy to do that.
Thanks, Cathy.
Thank you.
Any questions for Cathy before we move on, or maybe they'll come up during the presentations? Okay. Well, let's. Our second speaker is going to be Dr. Jayakumar with UCSD, and I'm going to pull her presentation up here.
So first of all, I'd like to say thank you, Cathy, because I think a lot of what you said is probably going to be more relevant and more important to you guys than a lot of what I'm going to say. I'm going to repeat some of the things that you've talked about, but in a little bit more depth. But again, I think the main point that Cathy's made very eloquently is talk to your doctor, ask any questions that you have. If you have any concerns about things that you're worried about, please let your doctor know and ask him questions. It's always better to ask questions and get everything out up front, as opposed to thinking to yourself afterwards, I wonder if it's this, and then worrying about it and spending sleepless nights worried about it. So, discussing primary biliary cholangitis. So, I don't have any financial disclosures. No one's giving me any money to be here or to talk to you guys. So I'm going to talk a little bit about the epidemiology of PBC, and epidemiology just kind of means similar to what Cathy was talking about, you know, how common is it, who gets it, what kind of people are at risk for it. We'll talk a little bit about the symptoms of PBC and how it's diagnosed, and what lab tests are commonly abnormal in the setting of PBC. I'm also going to talk a little bit about the effect of PBC on the rest of the body, so not just your liver, but other areas of the body that PBC can affect. We'll talk a little bit about the current treatments, and then I'm going to do a very quick slide on emerging treatments, because there's not a whole lot of data out there yet. So next slide, please. So Cathy went over this already, but PBC is a disease that affects the biliary tree, so the bile ducts. So basically what happens is that your liver cells, your liver is made up of two main kind of categories, the liver cells and then the bile cells. The liver cells will actually make the bile and then eject it into your bile ducts. Your bile ducts are like a tree, so, or a river if you will, so all the bile kind of gets in from the smaller and smaller bile ducts into bigger and bigger bile ducts. It gets stored in your gallbladder until you need it, and then from your gallbladder it gets ejected into your small intestine. So we're saying that your liver makes bile, and we're saying that your gallbladder stores it until you need it, If you don't have a gallbladder, it just stays in the large bile duct or the common bile duct. So what exactly do you need your bile for? You need it to help you digest fat and help you absorb some of the nutrients that are in fat, so what we call fat-soluble vitamins. So in people with PBC, what happens is that you end up getting, I like to liken it almost like to an allergic reaction. Your immune system starts attacking the lining of the bile ducts, and they get irritated. And initially, that irritation's there, nothing happens, but as that irritation goes on for long enough, you get scar tissue forming. Think about it like a scar. If you're outside working in the garden, you're using some tools, first little while, you're gonna have sore hands. They're gonna be red. As you continue using those tools and you get irritation, and that goes on for long enough, you develop calluses. Scar tissue in the liver and the bile ducts is the same way. As irritation goes on for long enough, you get scar tissue. As you get more and more irritation, that scar tissue builds up. So, how does that affect the liver? What happens is that the liver makes the bile, it secretes it into the bile ducts, and the bile's flowing along, think of it like a hose, and all of a sudden you've got an area of narrowing because that bile duct is scarred down. Now that bile can't exit outside that bile duct to get into your gallbladder or to your small intestine. So what happens is that bile backs up. And bile can actually be damaging to the liver if there's too much bile exposed to the liver cells. So that's how you get damage to the liver and how you get cirrhosis in a disease that actually involves the bile ducts. Does that make sense? So, two things. One, your bile isn't getting into your small intestine, so you're not going to be able to digest the fat and absorb those vitamins that you need. And two, that bile is backing up and going into a place where it shouldn't go. So, just like if you have a sewer, it's backing up, it's now going into your basement. Now the bile is going into your liver, and that's causing irritation, and that causes liver irritation in addition to the bile duct irritation, and then you get damage to the liver, and that continues long enough and you get cirrhosis. So that's how PBC affects the bile ducts, and it causes liver disease and cirrhosis. Next slide, please. So who gets PBC? So Cathy said it, mostly women. So even then, it's really rare. So if you have 1 million people, the number of people who have PBC, depending on where you are in the world, can range anywhere from 19 people out of 1 million to about 400 people out of 1 million. If you translate that into percentages, that's 1/100th of a percent, or 4/10th of a percent. So very, very small numbers. But it's rare, but it can still happen. And it can be devastating when it does. So I was saying that the rates of PBC change depending on where you live. So we do see it more commonly in European populations and North American populations. So less commonly seen in areas of Asia and Africa, but that doesn't mean that it doesn't exist there. It's more commonly seen in men than women, and the age range is also interesting. So it ranges around 30 to 65. It has been reported in people as young as 19. It has been reported in people as old as in their 70s and 80s. But the majority of people that present are in that age group. And as Cathy mentioned, a lot of patients will have other autoimmune diseases. So basically, if your immune system is acting up and it's attacking one area of your body, it's probably going to be attacking other areas of your body. So I've mentioned Sjogren's syndrome on there, and what that does is if that's actually an immune system or immune disease that attacks your salivary glands, so your ability to produce saliva, as well as your lacrimal glands, so your ability to produce tears. And PBC and Sjogren's syndrome are often seen hand in hand. Now, Sjogren's is actually when you have both your salivary and your lacrimal ducts affected. Sometimes people can get one and not the other, but either one or the other is often seen very commonly in association with PBC. People can also have thyroid problems, they can have arthritis, and they can have scleroderma, which is an inflammation of your connective tissues in the body. Next slide, please.
Can you?
Yeah.
Cathy mentioned
Hereditary?
fearful of that. Is it hereditary?
So Because it's an immune disease, and the immune system is very closely related to kind of hereditary things, we know that people who have a family member with PBC are 100 times more likely to get PBC themselves. Having said that, you're changing it from 0.0001% to 0.01%, so it's still really rare. But even though we know that there's an association and you're more likely to have PBC or autoimmune diseases if you have another family member with autoimmune disease, we can't really say it's because of this particular gene or this particular chromosome. It's not something that we can equate like color blindness or hemophilia. We just know that it seems to run in families, but we don't know exactly how it's inherited or if it is even inherited, because we don't know why some people get it and some people don't.
And then because of the gallbladder's ability to break down fat, is there increased risk for fatty liver disease, or just really not connected?
So the gallbladder just stores the bile, but the bile helps you digest the fat. You're right. So there's not really an increased association as far as I'm aware. That doesn't mean that there isn't. It just means that I'm not aware of it. With fatty liver on its own. So no. So in terms of symptoms, so there's not really anything specific that someone can point to and say, aha, you have this has to be PBC, because it's not seen in anything else other than PBC. What we do see, however, is a constellation of symptoms that make us a little bit worried that someone may have PBC. So, Cathy mentioned fatigue, and definitely a lot of our patients present with fatigue, but fatigue is not something that we can say, okay, you know what, you're tired, you have PBC, because you see fatigue with so many other things, including other liver diseases. Pruritus, or itching, can be seen in association with PBC, and it's actually one of the most common symptoms. So fatigue's number one, pruritus is number two. It can also be seen in some other liver diseases, but most commonly in PBC. And one of the things that people will tell us is that it's often worse in hot weather or at night. Now, as the disease progresses, you may notice jaundice or yellowing of the skin and the eyes. And then you can also get osteoporosis, so thinning of the bones or weakening of the bones. And we'll talk a little bit about that in a bit. Now, you can also have symptoms if your immune system is affecting other areas of your body, not related to the liver. So, as I said before, if you have Sjogren's and the immune system is attacking your salivary glands or your tear ducts, you can have dry mouth, you can have dry, itchy eyes, you can have both. You can also have pain in your joints if you have arthritis. And, if you can imagine, our saliva is there to help, be almost an antibacterial part and help keep our mouths clean, and it helps us break down food. If you aren't able to produce saliva, your mouth dries out and you're actually more prone to cavities. And we actually see that patients with PBC have a much higher rate of having dental problems and cavities than patients who don't, especially if they have salivary gland involvement. So if you wanted to go on. So, yeah, just click. So in terms of what do we see when we examine people? So lots of itching, and sometimes you can see people scratching and scratch marks on their skin. You can see something called xanthelasmas and xanthomas. So what that is little fat or lipid cholesterol deposits under the skin, and we mostly see it in the eye area as well as along the tendons. So we often see it around the elbow regions and on the knees. So that's a xanthelasma, so the little kind of yellowish deposits, and that's that. And that's xanthoma, so that's on the elbow. Bad teeth. And then if you progress, you can start developing the complications associated with cirrhosis, which are fluid building up on your legs or your belly. You can have yellowing of the skin, and you can have issues with bleeding. So next slide. So in terms of lab tests, so the alkaline phosphatase, or the ALP, is one of the main things that leads to the diagnosis of PBC. You can also see an elevation in your other liver enzymes. So your liver enzymes can be broken down into, is it affecting your liver cells, or is it affecting your bile ducts? Your alkaline phosphatase is a marker of something affecting your bile ducts. your AST and your ALT are often a marker of something affecting your liver cells. So you can imagine if you've got something affecting your bile ducts and it's plugging up your bile ducts so that your bile can't drain and it's backing up and affecting your liver cells, your AST and your ALT will be elevated. So most of the time, your ALP is going to be what's elevated. Some people will have a slight elevation in their AST and ALT. The diagnosis is often made with an elevated antimitochondrial antibody, but you can also see an elevation in a special type of protein called immunoglobulin M. A lot of people with PBC will have elevated cholesterol, and that can cause a lot of distress to people because they're thinking, great, I've got a liver disease and now I'm at risk for heart disease. The good thing, sort of, is that you may have a elevated cholesterol, but your good cholesterol is up and your bad cholesterol is up. And your risk of heart disease is really dependent on the ratio of your bad cholesterol to your good cholesterol. So even though patients with PBC may have an elevated cholesterol, the risk of heart disease isn't really higher because your good cholesterol is also high. If you do an ultrasound, the majority of the time the liver is going to be normal unless you have cirrhosis. So this is not a diagnosis we can make with an ultrasound or an MRI. And then if you do a liver biopsy, there's characteristic findings. So basically, if this is a disease that's attacking the bile ducts, you're going to start to see irritation and inflammation around the bile ducts, and sometimes you start seeing the bile ducts disappearing because of that irritation and scar tissue. Next slide. So non-liver complications of PBC. So like I said, bile helps absorb the fat, but it also helps absorb the fat-soluble vitamins. So if you can't absorb fat, if you're eating a fatty meal, you're going to have diarrhea. So just like if you go to Taco Bell and you have a really high-fat food meal, and you're going to pay for it the next day on the toilet, in PBC, it's like all of your meals are Taco Bell. And all that food, all that fat, even if it's not very much fat, isn't able to be digested. So a lot of our patients will have diarrhea, long-standing diarrhea. Then there's certain vitamins that are in fat. They're what we call fat-soluble vitamins. And so when you don't have bile being secreted into your intestines, you can't absorb those vitamins. So those vitamins are vitamin A, vitamin D, vitamin E, and vitamin K. So in terms of what do those vitamins do, vitamin K helps make clotting proteins. So in people who have PBC, who have advanced disease, and they're not able to absorb that vitamin K, they may start noticing increasing bruising and bleeding. Vitamin D is important for bone health. So in patients who have PBC, you are at higher risk for developing osteoporosis and bone fractures. Vitamin A, it's in carrots. We use carrots to help see. So people who are deficient in vitamin A will often have night blindness. And finally, vitamin E is used to help preserve nerve health, as well as to produce some red blood cells. So if you're deficient in vitamin E, you may have neurological problems, and you may have destruction of your red blood cells. So you may be anemic. Next slide, please. So in treatment, so the way I explain to patients about PBC is it's like high blood pressure. You can't take a pill for a number of days and then be cured and then be off the pill. This is, if you're on medication, this is a medication you'll have to take for the rest of your life to help keep the disease under control. So really the main goal is to slow things down or to stop the progression so it doesn't get any worse. So that's treatment of the disease, but we treat people as a whole person. We don't just look at you as a walking liver. So we want to treat the disease, but we also want to treat, the complications of the disease. So making sure you don't develop bone problems, or if you have bone problems, treating those. Making sure that if you've got diarrhea, we fix that and help you deal with that. Treating the itching, and then treating the dry eyes and the dry mouth. And then most importantly, treating your overall well-being and psychological health as well. So next slide, please. In terms of the treatment of PBC, the two kind of main approved treatments are ursodeoxycholic acid and then obeticholic acid. Interesting story about ursodeoxycholic acid. So your bile, when it sits around, can form gallstones. So that's why people form gallstones. And so somebody, some genius at one point was like, bears hibernate for 6 months out of the year. Why don't bears get gallstones? Because that bile is just sitting around. And someone actually analyzed the bile in bears, and they found that the bile was very different and kind of more runny than it is in humans. And so ursodeoxycholic acid is actually the synthetic form of the bile acid that's predominantly found in bears. And the way I think about it is it actually makes your bile less irritating, and so it's not as inflammatory. And also, it changes the consistency of your bile. So if you think of your bile normally to be the consistency of motor oil, urso is probably going to change it to the consistency of cooking oil. So it's kind of more runny, and it gets past those areas that are scarred more quickly without kind of getting caught up and sludged up in those areas that are scarred. A beta-cholic acid is a form of a already occurring bile acid called quinodeoxycholic acid that seems to cause decreased inflammation. Now, ursodeoxycholic acid has been around for a long time. It's actually been shown in patients with early stage disease to delay progression to cirrhosis or to requiring a transplant. It's been shown to normalize your liver tests and actually improve biopsy findings. A beta-cholic acid's been around for a much shorter time period, so it's hard to say, okay, you know what, it improves lifespan or it improves time to transplant when the average time to even if you say that in worst cases it's about 10 years to transplant or death, it hasn't been around that long. What we do know is that ursodeoxycholic acid seems to normalize numbers, so your ALP. But it's still fairly early in the stages, and we don't know if it's going to change outcomes in terms of how long it's going to take people to get to transplant or to cirrhosis on treatment versus not on treatment. What we do know is that being on treatment is definitely much more helpful long-term than not being on anything. Next slide. And then there's experimental treatments. So there's a number of different drugs that are still under study that aren't available at all. And so you can only access those medications if you enroll in a clinical trial. But there are other medications that are already out there that either alter your immune system, so suppress your immune system, or suppress your cholesterol profile. And there's studies that are underway throughout the world looking at whether the combination of those medications that are already available with ursodiol will actually alter outcomes or not. So it's something that, people who don't respond sufficiently or suboptimally or don't respond at all to just pure ursodiol and for whatever reason can't be enrolled in a clinical trial, there are other options. And that is my talk.
Do you want any questions, or do you want to go on to Dr. Gish? And I think what we planned with Dr. Gish was to add another voice and kind of comment on what you've heard, and then add to anything you'd like to add.
I think I'll make my part very short. I think you did a great job. Thank you very much. And yeah, it was
Maybe
great.
Can we get you to move to the hot seat? One of the hot seats. Thank you, Dr. Gish.
Take over the camera from where it's there, but why not? Sounds great. So I'm just going to make maybe 3 or 4 comments. One has to do with working with the PBCers. And how is Lenny? Is she okay?
She's doing there.
Say hello to her for us. So Lenny helped found the PBCers and has been the person I've communicated with extensively about many things. And the name change was one of those. And I was in London in 2013. They had a PBC organizational event just before EASL. EASL's the European Association for the Study of Liver, and there were probably 150, 200 people in the room, including Alan Hoffman, the person that really discovered URSO here in San Diego. He's one of the key people that found out the favorable effects of this bile acid, and really led eventually to its commercialization, and was also essential in the beta-cholic acid development with Intercept. He's been an advisor to Intercept when Intercept was founded, I think 2002, did I get that right? Year? it was 2002. So anyway, there was this meeting, there were advisors, scientists, clinicians, patients, the PBC Foundation, people were there. And towards the end of the meeting, we had this large panel discussion, and representing the patients that I work with, I stood up and asked the moderator, David Jones, about wasn't it time to change the name because there were so many problems with the patient being labeled with cirrhosis, which Cathy highlighted so nicely. And he just waved his hand and said, forget it, that'll never happen. We tried that over the last 20 years. Nobody wants to change the name, or nobody can change the name. It was just like, very, very, very dismissive. So I sat down, didn't say anything else, so I wasn't going to get into an engagement in front of 200 people. But Robert Tane Mitchell, who works with the PBC Foundation, he and I got to know each other a little bit before that meeting, and we kind of ganged up on David Jones after he had some wine and cheese an hour later. And 15 minutes later, he did a 180-degree and said, we're going to change the name, we're going to make this happen. And just a few weeks later in Italy, in Milan, there was a PBC meeting, which I couldn't attend because I had other things that were occupying my calendar. But Robert Tane Mitchell was given permission to present a rapid survey that he had done in collaboration with the PBCers to all the research scientists on PBC at this EASL meeting. And that really fired the cannon and got things moving. A man named Ulrich Buers, who's Dutch, myself, Chris Cowdley, just a whole number of other people exchanged somewhere around 1,000 emails, 200 phone calls, letters, arguments, all sorts of things. And there were some pretty negative people on the physician side. Wasn't a single negative patient or patient advocate or patient support person that was against this. Doctors tend to be, obstreperous at times. Obstructive, a few of them. But then it was decided that we had a consensus, meaning about 95% of people agreed to the name change, and Ulrich decided he was going to produce 7 manuscripts in 7 journals simultaneously, which he did with all of our help, and that changed the name. We got it out there in the scientific community, and now almost everybody accepts this name change, that it's fair, it's correct. Could be a little bit better. There's still some people arguing about semantics. The PSC people threw up a bit of a fit towards right before we got all the things approved and the publications done, but they're still our friends. So anyway, the name change is in effect. It's benefited patients immensely. There's a few physicians who still grumble, but probably because they didn't think of it. And it's really time that patients be tuned in to the fact this is not a stigma, it's not a fatal disease for most people now, and there's multiple treatments that we have available. So I think that's it's very, very exciting that we could work together. The community could work together. The patients could work with the advocacy organizations, with the physicians. It was a very rewarding time.
It doesn't happen. It just doesn't happen. Disease names don't change.
Mm-hmm. Yeah, it's almost, it's very rare. They've gone a lot from people's names to disease names, but not disease names to disease names, right? Where they've shifted things, and you could change codes and really, and then getting a journal article published, the same article published in 7 journals. I've never seen that in my career. I don't think there is a case anyplace in the world, medical history of that happening. So that was, I think, very, very important. Just to preface that, I think the discussion that we had about the clinical aspects, and I just got a document that I haven't read yet, but it's about all the different drugs that are in development for PBC, and there's probably another 10 plus drugs that are in, and there's a company called Simibai, who's got what's called a PPAR drug. It's PPAR, that's in clinical trials right now. And there's a number of other companies that I consult with that have PBC on their radar for drug development with a lot of other interesting pathways. These compounds that we have here based off URSO are fairly crude drugs, kind of hitting broad base, not necessarily on target. Although there's a really, really nice paper on this bezafibrate that was published at EASL last year that showed profound reductions in alkaline phosphatase with this medication that's really meant to lower fats and lipids in people's blood. So it's a little bit of an accident that they found this, but it was a large prospective trial, and they really tried to hit the home run which is my main comment next, which is an alkaline phosphatase should be normal. So we have all these surrogate endpoints, the global study, which is this huge database that was set up around the world looking at surrogates for outcomes. But the lower the alkaline phosphatase, the better the outcome. This is a natural history of PBC. It's with URSO data, and we think that'll be replicated with obeticholic acid. So any abnormality in alkaline phosphatase indicates a higher risk of progression to death or transplant. Our ultimate goal with all of our therapies is to get the alkaline phosphatase normal. It's not down 15%, it's not 1.67. Please.
What if it's been steady but above normal, like slightly above normal?
So anything abnormal is worse than normal, okay? And we learned that with the liver enzymes, right? Alkaline phosphatase is one of the liver enzymes, but AST and ALT are other liver enzymes. We've learned we've been wrong for 40 years about what a normal AST and ALT is. A woman should have an AST or ALT under 20. A man should have an AST and ALT under 30. That's healthy. So what's a healthy alkaline phosphatase? Right now, it's a normal alkaline phosphatase. It might even be lower than normal, but we're going to say...
Okay, so what's normal?
So it depends on the lab, but it's usually in the 100 to 130 range. I'll throw out 117 just to throw out a number. That's somewhere in there. So any elevation's a problem, but then there's more to it than that. You know, if you really want to know, you get a liver biopsy every year, right? No, I'm not going to do that. We already heard the liver biopsies aren't going to happen in most people. For some reason, people don't like liver biopsies. I've done 8,000 liver biopsies, and
Still
people
don't
don't
like
complain, but I agree, biopsies aren't needed, but we have something called elastography. How many people here have had elastography done for their liver?
Is that the
I was in the
fibroscan?
study.
No?
Well, we'll talk about that in a second, but any type of elastography. Anybody? Okay, so that's, to me, the new standard. You walk into a liver doctor's office, you get your blood pressure, you get your pulse, you get your temperature, you get your weight, you get your elastography. So if you haven't had that done, you should be asking to get
Is
that
that done in the doctor's office?
Radiology, doctor's office, clinic, it just depends where the machine is, but either you find the machine or the machine finds you.
Okay.
So elastography, one of the names for elastography is FibroScan.
Oh, okay.
So that was the first commercial one that was on the market, but there are Philips, GE, Siemens, Supersonic, you know, there's all these companies, including what's called magnetic resonance elastography. So we have at least 5 different kinds and probably 10 plus manufacturers. Painless test, takes 7 to 10 minutes. I've had it done on me 3 or 4 times, usually for demonstration. I was a little scared, but I'm normal.
Didn't hurt anybody at all? Like the pounding?
No, it's a light tapping.
No, I mean, I had it. I
Yeah.
thought it hurt a little bit,
Yeah.
but
Yeah, it's just a
Mm.
on the skin. But
maybe it was his first time.
yeah, it's probably more anxiety. But, and there are other machines they have don't necessarily even have the tapping. They have other ways that they do sound transmission. That's the first generation, but that machine, now that they've done improvements, is still first line. It's still one of the first line options. So think about that. There's FibroScan machines or elastography machines, you know, basically in every major city now, at every major liver center. Go, please.
I had a liver biopsy. When should I, if I should get one of these done, or how often?
I'm on my patients get one elastography test once a year. That might be a little excessive. It might be every 2 to 3 years, but I would get one annually for 3 years, see what the trajectory is. And I'm not just checking elastography. I might be checking an ultrasound. How big is the spleen? How big is the portal vein? Those are ways of measuring liver damage indirectly. I'm going to watch the platelet count. I might calculate something called a FIB4, which is a calculation of enzymes and platelet count. So, but annually would be a good start, but then you negotiate after that how often to get them done. So there are people who have elevated alkaline phosphatase that never progress. And URSO is one of the treatments that slows progression. We know that in terms of natural history, on treatment, improving outcomes for patients. And we think that same thing will happen with obeticholic acid. So annually is my answer.
But you
Yes.
shouldn't be getting surveillance liver biopsies.
Yeah, that's what I think you
Yeah.
asked biopsy. He's not saying biopsy.
No,
You're asking about elastography.
yes.
Yeah.
No, I just said I had a liver biopsy.
Okay.
Yeah.
No, I want to know.
I don't know anybody who wants one.
The problem is with the liver biopsies, you're sampling about 1/50,000th of the liver, and maybe with a really good procedure, you're getting 125,000th of the liver, but it's a very small sample. Elastography looks at 10 to 15% of the liver, depending on how the scan's done.
I just had a question. When I was diagnosed, it was around 1995, and at that time, I was put on Activol.
Same thing as Urso.
Okay, so it
Just
is
a
the
brand
same
name.
thing. Okay.
Ursodiol, Urso, Actigol, ursodeoxycholic
They don't
acid.
use Activol.
They're all the same.
Yeah.
That was just a brand name at the
Brand
time.
name.
Remember, they developed that not for PBC, but to dissolve gallstones?
Yeah.
That failed. It was like the machine they used to break up gallstones with, sound waves.
Wow.
That was a big
So they
fad.
were lucky that it worked on something else.
Yeah, it was a treatment looking for other diseases, and fortunately,
And the colchicine, because originally they put me on that, and then they said it's not necessary.
that failed. The study with colchicine failed. Colchicine's good for gout.
Yeah, yeah,
Or if you're having constipation.
yeah. So it helps with constipation.
If you get too much, it gives you really bad diarrhea. You shouldn't use it for constipation.
Okay.
I mean, there are studies that prednisone or mycophenolate works for PBC, or even cyclosporin, but the side effects are much worse than at least the laboratory benefit. So they've dropped off the radar, at least for now. With budesonide may come back because it's got less systemic side effects. It's a steroid. So we have a round table. It's whatever questions you have. I think we really can have a chat, because I didn't want to come here and add on to this beautiful lecture that we had, or the beautiful intro.
Well, if nobody else, I don't want to dominate, if nobody else has a question. When you were talking about the different vitamins, and I think you said vitamin E
Yes.
had something to do with neurology.
Deficiencies of vitamin E can cause neurological issues.
Could that do anything with neuropathy?
It can.
So I have to check vitamin E.
You
Check the
should
level.
check A, D, E, and K.
Okay.
How do they, are they through supplements or?
There are,
through-
in fact, there's actually supplements that will just sell vitamin A, D, E, and K.
ADEC.
ADEC. But the amounts that you need as someone with PBC of each of those vitamins is insufficient. So, someone with PBC should probably be, I use 2,000 international units per day of vitamin D.
D3.
Yeah, D3. But, that's not what you're going to be getting in a lot of the multivitamins and everything. So it's probably better to kind of use each individual one as opposed to the
So
combination.
it's not necessarily that you can get all the vitamins through diet alone.
No.
It's really supplements too.
You wouldn't be able to absorb it just through diet alone, unfortunately.
Now, early PBC, people may have normal vitamin levels, but as soon as you see the bilirubin start to increase, and there's been a really, really interesting article at AASLD from a Canadian/global study, that as soon as the direct bilirubin becomes abnormal and the total is over 0.6, that means there's very significant liver damage and you're starting to see liver dysfunction. AST and ALT are not liver function tests. There are people still using that term everywhere, but it's not. It's like the earth is flat. Those are liver enzymes. They have nothing to do with function. The bilirubin's a very sensitive liver function test. And direct bilirubin, every liver patient should be having their bilirubin fractionated when you get a liver panel. Not all providers do that either. Hoping you do. Okay, good. All right. Make sure we're on the same page. So the direct bilirubin is the sign of liver health, and a healthy person should be 0.3 or less. You saw these beautiful pictures that the small bile ducts are getting destroyed by these inflammatory cells, right? They're turned on against this E2 of pyruvate dehydrogenase, and T cells and B cells are interacting. As soon as the bilirubin, the direct bilirubin, starts creeping above 0.3, you know you've got substantial small bile duct damage. That's real liver dysfunction. So what about varices? How many people here have had an endoscopy, upper endoscopy?
Oh, what?
Scope into the tummy. Okay. PBC patients get varices much earlier than other patients, meaning at earlier stages of fibrosis. I'm not sure exactly why, but whatever's attacking these bile ducts seems to be constricting blood flow through the liver, through the portal vein. So they get dilated veins in the esophagus called varices, like big hemorrhoids in the esophagus. And they may need to be observed, treated, banded. So basically, anybody that's going from stage 2 to 3 should definitely have an endoscopy at that time, and then maybe every 2 to 3 years.
My aunt just had that a week ago because I found out she has liver disease, but it's not PBC, it's just cirrhosis of the liver. Both my aunts have that.
So the upper endoscopy would be part of staging how severe their liver disease is. What's their prognosis? If you've got varices, the prognosis is much
Hers got
worse.
banded.
So then that means they're not just varices, but they're big. And rubber banding helps shrink
Since
them.
they have liver disease, does that just run in the family, liver issues in? Or is mine still different than theirs?
That would require a full chart review of your family members. We wouldn't necessarily be able to say they're related or not now. There is a genetic predisposition.
Because we all have a thyroid condition, all of us women.
So it could be they had autoimmune liver disease of a different type. PBC is autoimmune, but there's 17 different types of autoimmune hepatitis. All right, so you just, PBC's, autoimmune cholangitis, IgG4, classic autoimmune hepatitis, sarcoid, very long list. This is in the family. So they potentially could have autoimmune liver disease that's related to PBC, or it's in that family. They've got liver specialists they're seeing?
Yes, they both have fatty livers, and I guess they're both in a cirrhosis stage.
So fatty liver probably is competing directly with hepatitis C and alcohol for the lead position in causing cirrhosis. So if somebody comes in
Neither
with,
one of them drink.
right? So eating food is as bad as drinking
And
if
that's
you're
the
overweight.
problem. They're the typical Hispanics, so yes, they don't eat properly.
So it's behavior and
Fair to
genetics.
say.
So it's probably fatty liver, not autoimmune.
Okay.
But the good news is, with good diet and exercise, if you catch fatty liver early, you can reverse that. I had one little spot of fatty liver, and I lost 10% of my body weight, and my next imaging, poof, gone, right? So better eating, better exercise, makes your liver healthier overall, which is good if you have PBC.
Weight loss is key.
Yeah.
Which is when you talk about name change, I told my doctor, the name fatty liver, okay, is really, in my opinion, not a good name to tell a patient, because many of us were overweight, and when we hear fatty liver, it's just like calling you another name. So I said to him, you would be better off giving me the technical name rather than saying, I think you have fatty liver, because I don't want to hear about it. So it turns out I did, and I did lose weight, and it did get better. So there is, thank goodness, something that you can do about
That's
it.
good.
But I think just as talking about name changes, I think for doctors, maybe they might think about that. So, just a comment.
With your epidemiological profile, so at the worst case, then there's about 1,400 people in San Diego with PBC,
It's likely.
likely.
I think those numbers are accurate. And there's a lot of PBC. I was in Shanghai in December and was at this drug development symposium. There's a lot of PBC in China. It just
Is
gets
that right?
it gets buried in the hepatitis B
Wow.
noise.
Wow.
And of course, fatty livers, the Chinese are catching up with us in many ways, including their BMI. But yeah, PBC is everywhere. It's been under-tested, under-recognized because, well, in China, people who manage liver disease or infectious disease docs, and they never look for autoimmune disease. It was either Hep B or we don't know.
No,
You know?
no.
On the itching, you had mentioned that in hot weather, it gets worse. What's the experience like in Minnesota in the winter? Does it kind of go away so you love winters, or is it always there?
No, totally.
Itching with PBC is really hard to describe to somebody who's never experienced it. it's under the skin, so it's not an itch like a topical itch,
Oh.
right? We have long used cold compresses to help with that, but cold weather in and of itself doesn't seem to affect most itch. It dries our skin out, which doesn't help, but generally, the people that live up in the Northeast, and they still have itch all year long, unfortunately.
You said something about getting a specific type of bilirubin test, like fragmented or something?
Fractionated.
Fractionated?
Total bilirubin, then we split it. Fractionate. Direct, indirect. So when your body breaks down red blood cells and other things, bilirubin is one of the chemicals that's made. And then your body wants to get rid of bilirubin because the bilirubin that comes out of red cells and other tissue, cytochrome, things like that, goes right to the eyes, makes your skin yellow, your eyes yellow. But your body says, oh, we're going to glucuronidate. We're going to add something on, and then you can pee it out in your urine. So that's the direct is conjugated. The indirect is the free, or the lipid soluble. How the liver works, how much it's conjugating, is very important, right? So you get this conjugated bilirubin that starts rising, and it's made, but it's not secreted. It's not being secreted in the urine or more likely in the biliary tree. So fractionate the bilirubin and focus on the direct bilirubin. That's what you should be graphing out. Do you all have tables where you follow your liver tests?
But they're always different. I mean, the tests the doctors do seem to always be different.
There's gonna be
No,
peaks and valleys, and they're gonna run some tests
Now the
sometimes.
results are different.
Yeah.
No,
What they order.
The tests the doctors do
Yeah.
are not the same.
No, I
So
understand.
sometimes I have direct, sometimes it's just total.
Right.
Demand consistency.
Yep.
How do I know what they're doing until I get the results?
But track them. If you want, I can send you a spreadsheet that we've developed to do that.
Great.
And it lists all those tests that he's talked about, so that you'll have a history of what your tests have done over time. And if you're not getting both views of your bilirubin, it's on my list.
Do you ask your provider what tests they're ordering?
A liver panel, I think, is what.
So you're going to ask them more specifically, what tests are you ordering? Can we double check that it's on my PBC checklist?
I don't find that my doctors, well, I've had several doctors through the years, obviously, so I don't usually find that they want to have those conversations, so.
I would recommend finding one that has those conversations.
Yeah.
I'm hoping that from this group, maybe I'm going to find one.
It's,
Because we just moved here, so.
this is a friendly, collaborative process with patients. And most of the patients know more than their providers. That's probably what they're afraid of.
One of the other things is that based on which lab you're going to and where the blood work is being ordered, a liver panel can mean something very different.
Totally
So
agree.
exactly as Dr. Gish said, you know, having consistency, but sometimes, you know, especially if you're like me and you don't like confrontation or like you don't want to necessarily come off as though you're questioning someone, one of the things you can say is, you know, I really like tracking my results and keeping it in a file, but I notice that my results are different based on where I get my lab work done. Can you please make sure that these 3 tests, so the direct, total bilirubin, and the ALP, are being ordered with every blood work? And that, you know, if you're not comfortable kind of saying, why aren't I getting this? You know, that might be kind of a slightly more non-confrontational way to do it, but also to achieve what you want, which is really kind
To
of,
know what to ask for is
Exactly.
probably the very first
For sure.
thing. So this is very helpful right now. I've only had it for, 8 years now? So,
Yeah, I have to say, I've been with my wife to, I don't know, a dozen of these kinds of meetings through the years.
not here.
This is probably the best
Oh,
one
man.
we've ever been to. I felt that your presentation was so full of great detail, and the 2 of you doctors are really giving really relevant information, not just kind of talking about your research and the work you're doing and the industry in general, but specific, useful information for patients you are conveying is really notably great compared to most of what we hear. And Cathy, you don't speak a lot at all these presentations. You kind of introduce people, but your story is an emotionally compelling and really, I think, somewhat comforting story to hear. You have a really important message also. It really was great to hear you speak.
The impact that I mentioned was the group of PBC cohort that works with the American Liver Foundation. In 2016, we all got together and did a bunch of snippets about PBC from a patient's perspective. They're on YouTube. Go look at those. They're 2, 3, 4 minutes long each, but we covered in our own words what that specific issue about living with PBC is like. So it's really interesting and why I do what I do, because as Dr. Gish so eloquently put, sometimes we know more than our doctors do. I've had to educate my own liver doctor to the point of sicking another doctor on him to go tell him, know this. And he called me that night and he goes, well, now I understand what you were saying. So don't be afraid to engage your doctor, respectfully always, but you know, I'm learning about this disease every day. So I've learned or heard or this doctor said, so I'd like to explore this. However it works for you, but it's your body, you have a right to know what's going on in it.
I'm going to be very simple. There's two types of providers, the one that get out of school and stop learning, and they're just learning a little bit. Then there's people who collaborate and listen to other people. And I think I travel all over the world. I was in India this week for a whole week, and I went to this big meeting in southern India. 2 days I'm sitting in a room just taking notes and hearing about all sorts of things about liver transplant, liver failure. Never stopped learning. In fact, my head was completely spinning by the end of those 2 days. So you got to find a provider that's still learning. They may be a leader, but usually leaders are also still learning.
Well, if anyone, we're in Orange County, in southern Orange County, so if anybody has a recommendation for a provider, I would love to hear about it.
So probably in southern Orange County, either you drive to San Diego or you drive to Los Angeles and get to one of the hepatologists, either USC, Cedars, or UCLA. Those might be the best places.
Okay.
There's a couple hepatologists at UC Irvine. I just don't know if any of them have a skill set that's in PBC or not. You can just send me an email. I can get you the docs that would be potential for you. Just go to my websites, rgish@robertgish.com.
Great, thank you so much.
I'll be glad to guide you.
Doctors in Loma Linda Transplant Center.
So there's
Like
hepatologists.
Dr. Volk.
Dr. Volk's fantastic. So I didn't quite go that far east, but he's a very, very experienced person. Came from Michigan. Yeah.
There are doctors who are real experts in PBC. Most doctors may have a patient or 2 or 3 that they've treated with PBC, but then there are the clinicians that are knee-deep in it and know it in and out. So if you can find one in your area, that's the best scenario. If you can't, query them. How many PBC patients do you have? How have you treated them? If you're not comfortable, find another one.
I think he was the closest to me.
You know, that's how we fall into them. This is your life, so you deserve to find somebody you can work with.
We've got 5 more minutes. I want to be respectful 4 minutes of everyone's time.
Scott, 1 second. Look, you had your hand up a number of times, so maybe you could.
Yeah, I'm wondering if either of you would know where what phase the fibrate, the clinical trials are. Like, is the issue currently safety, which I think is phase 1, or are they safe, like for PBC, and is it about efficacy of this, whether or not it works?
Cathy, you have that?
I have my list. There are several trials in phase 2 that are bile acid-based therapies. Gilead has one. The Simba Bay that was mentioned has one. Novartis has one. And you can go to clinicaltrials.gov and type in PBC. It'll show you all the studies that are currently underway.
Yeah, my issue is fenofibrate was prescribed for me.
Oh, okay.
Yeah,
Okay.
So I want to know where.
Sure.
So
where this is.
I'm going to
Phase
predict the
one, phase
future.
two.
In the U.S., bezafibrate and fenofibrate will probably never be approved by the FDA. They are generic drugs. Bezafibrate is not available in the U.S.
Right.
And in the EU, you can find bezafibrate. It's got at least 10 different brand names, and it's been used for lipid-lowering agent. There's no money for pharma to develop a drug that's a generic for a new indication unless they can get a label, an isolated label that protects their IP. And then that's a risk. So they might go through $100 million and not get the label because somebody's challenging their intellectual property. So those two drugs will probably be used off-label after we get some large phase 3 studies done. The bezafibrate study that was done in Europe, I believe had over 200 patients. It was a large study. And it was absolutely incredible how many patients normalize their alkaline phosphatase. That was their endpoint. And normal, not some modest reduction. But diarrhea, muscle, kidney, these drugs have got side effects that are probably in the 5 to 7% range. So AEs with URSO that would take somebody off therapy because it was life-threatening, almost unheard of. 7% of people can't tolerate URSO. I think what you described is itching, fatigue, hair loss, diarrhea. I don't know what your side effect was, but it's...
It was the itching and I kept getting sick to my stomach.
nausea.
So I had that problem too when I started it, and so I'm still on a half dose of what I should be on for my weight, because I couldn't tolerate it. But at a half dose, I normalized within a few weeks, and my numbers have been good ever since. I was supposed to be on like 1,000 or 1,200 or something like that, and right now I take 3 a day. I take, what is it, 250?
250s?
Yeah.
But you were on 2 to 3 a day, like every other day or something.
So,
I'm on the Budesonide now.
Budesonide?
Yeah,
Mhm.
I'm on that now.
And you haven't been tried on obeticholic acid?
No.
So for people
I
who...
went from the Urso to the Oclavia, or how do you say that?
Ocaliva,
That, and then to Bud.
and you're still on Ocaliva.
No, I'm on the Budesonide now.
And
So
what
you
happened?
couldn't do
Month and a half
either?
now.
What?
He took me off of the other one because he says, it wasn't, he says it was bad trials that he's seen on it, and he didn't want me to, anything to happen to me. I don't know, this is what he said.
Okay,
I
so
don't know.
Ocaliva has not gotten a black box warning at this time. There's still negotiations. Am I still correct with that? There's still nothing? So there were physicians around the world that
That was
used...
Dr. Wilkins.
Oh, I don't want to say too much, but
Just-
Ocaliva is first-line therapy for PBC in people who failed URSO, right? So I'm just going to make that statement.
As long as you don't have decompensated liver or very advanced liver disease.
That's where people got into trouble with Ocaliva. At least half the patients who had these serious adverse events from Ocaliva had advanced liver disease and were given full dose. So it wasn't a bad study. It was administration of the drug in excess of what was in the label.
So which one is better?
The standard for you right now would be to be on Ocaliva, from what you just described. I haven't seen your case, I want to be cautious, but that's what the standard would be at this time. Budesonide is experimental. That's off-label. There's no significant studies, prospective studies showing a benefit yet.
Especially budesonide on its own.
Especially what?
On its own.
Did you try to ramp up your URSO dial rather than starting at the full? A lot of patients do better, especially if they have reactions.
We did the
We go
900.
slow and then add and add.
We did,
Okay,
and it was still upsetting my stomach.
okay.
And
That's,
a lot of stomach cramps, and I couldn't do anything with it.
Did your bilirubin change on Ocaliva?
I have to go back and look.
It's good to look. So every patient I see with autoimmune liver disease, I've got hundreds of patients that I follow, every single one has an Excel spreadsheet, and they plug in their medicines and their liver tests every time their labs come
I
in.
usually look at I get all my results, and I look at all them from each time I get it to see what's went up and what's went down, but I still don't understand all of it.
You've got to put you basically put a table together, and then inside Excel, you can make a graph. And you can look at yourself back 1, 3, 5 years.
I have one, I'm happy to email it to you.
This is really standard, I think.
Yeah.
There's also an app, Living with PBC, which is kind of a nice way to track it if you just want to do it on your phone, you don't want to pull up a laptop.
then there's some information there, so it's just a generic, app where it has, all of the different, your ALP, your bilirubin, your ALP, your AST, and you can just input all the numbers, in there, so there's information there.
So your body is a whole entity, right? We don't live in a vacuum. We're not just PBC. And things that you may not think are part of that, but can affect or have other autoimmune issues, can be in that same grouping. So I think it's important that you look at your entire picture and not just focus on the liver.
No, yeah, I
Right.
have the Hashimoto's disease too.
Yeah,
So-
you've got thyroid, so
And
yeah.
then
Just remember, you're a whole body, right? Nothing lives in a vacuum.
We call it a systemic disease with liver involvement. It's not a liver disease. It's a whole
Yes.
body disease. And each patient's got to be looked in their entirety.